Good morning, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Doing quite well, thank you.
Dr. Robert Murphy is the executive director of the Havey Institute for Global Health and the John Philip Bair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week here on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing a viewer-submitted question, the latest headlines, and talking about the statistics we're missing through today, October 24th. We invite you to submit any questions or comments down below or at any of our social media linked in the description. Looking at our statistics for this week, last week there was an average of 92 deaths per day from COVID. Unfortunately, we do not have updates during this shutdown, but your reactions, Dr. Murphy?
Well, one way to deal with the problem is to just stop collecting statistics. So there's really nothing to report. There are still cases of COVID going, and we haven't started the COVID winter season. We just got over the summer bump, which we had, which was, of course, much milder than the bump in 2024. So that's good news, but there's still COVID. Diagnosed a couple cases last week. So it's out there. We don't know how bad it is because nobody's there to really look. All those people are either furloughed or fired. It's very important. On the good news side, though, is at the University of Minnesota, they have a center there that's following a lot of statistics and doing their own kind of analysis of state reporting. And they're going to basically become sort of the new CDC in terms of reporting disease outbreaks and what the CDC used to do. So I think that's going to grow, and it'll be we'll at least have some authority there that's trying to put things together. That's Dr. Osterholm and that group up of Minnesota. Excellent group, and we look forward to hearing more from them.
Yeah, excellent, and happy to be neighbors with our Minnesotan colleagues. So thank you to them. We do have a submitted question today from a longtime viewer who wonders that when they received their flu and COVID vaccines this year through work, they were informed that there is no longer that 3-month waiting period if you have a COVID infection and want to receive a vaccine. Is that the right advice?
No, that hasn't changed as far as I'm concerned. I think what's happening, though, is the COVID vaccine guidelines have changed multiple times over the last couple of months. And I think there's confusion with the pharmacists who are now at the major pharmacies giving most of the vaccines rather than hospitals and clinics. Although this person, I don't know where they were. They received it. I can't remember where they. I don't know if it was. They said where they got it, but the pharmacist told them, you know that there is no more waiting. Well, the reason why the waiting is put in the first place is that when you have especially a bad COVID infection, you already have like a big pile of antibodies out there. So do you need more stimulus from the vaccine? Because we know those antibodies don't last. So you give it a couple months, it sort of antibodies actually start coming down almost very quickly. And so the vaccine will do you more good if you wait a few months. There's no safety issue. So that's one thing. So if that's the only time this person is going to take the vaccine, go ahead and take it. You're going to get a better bang for your buck if you wait 3 months or a little bit longer. So I think it's just the overall confusion in who's supposed to take it. The person's obviously eligible, so they said, oh, "Yeah, you can take it. You don't have to wait." But the rules or the guidelines, if there are any guidelines left that are worth reading, haven't really changed. And it's because of the same thing. This was one of the early questions we got many years ago during the pandemic when the vaccines were available. So it's been looked at multiple times. It's not a safety issue. I'd wait 3 months if I were you, but that's a reasonable thing. But if you just don't think you're going to get around to it in 3 months, take it now.
Hmm. And speaking about that vaccine eligibility, great to know that pregnant women now are included. And some of the reasoning behind that. There was an excellent study just published about the dangers of COVID-19 infection in the different phases of pregnancy. Can you break it down for us?
Yeah, well, we've known for a long time that COVID in pregnancy is bad. And to take healthy pregnant women out of the COVID recommendations was a very foolish thing to do because during pregnancy, your pregnant women are susceptible to many infections. And that was a giant mistake, and that actually did get reversed and put back into the guidelines. None of the professional societies recommended not to give the COVID vaccine during pregnancy. But the government, and it's a yo-yo effect here, was back and forth, back and forth. So, of course, now people are confused. And then there's the whole movement not to take any vaccines. So this was a very nice study. 13,422 pregnant women. All right. Of them, 6,700 got COVID, documented COVID infection, and it was split pretty evenly between the first trimester, the second trimester, and the third trimester. The women that got COVID, actual COVID infection in the third trimester. Now, these are women who are getting diagnosed. So, they probably have, moderate to severe infection, had over 4 times the rate of ending up in the ICU and over 7 times the rate of being put on a ventilator compared to women who got the infection in the first or second trimester. All right. So the later on in the pregnancy, the worse they did. And this is just very unfortunate. And so pregnant women really need to be protected against getting COVID. And there is a vaccine and it's safe during pregnancy. That has been proven. And it's certainly going to be worse if you get COVID, especially in that third trimester.
Very important data there. And moving on to other viruses in our big three for the respiratory season. This time, RSV, respiratory syncytial, virus. There's great data that just came out about different vaccination types for pregnant women, and along with that, the monoclonal antibody for infants. Can you break down those results as well?
Yeah, it's a little bit confusing to explain, but let's just go back to the basics for 1 minute here. RSV, this respiratory syncytial virus, is one of the three big viruses that can cause pneumonia that can kill you. All right. And for RSV, the primary type of people that have serious disease and can die are infants up to 1 or 2 years and older people, particularly 75 and older. All right. But even those down to age 60 who have any underlying condition, which is a lot of them, they would benefit from it. So this study looks at the impact for the infants. So one way to treat the infants is to give them an antibody that's already manufactured, and you give it to the infant, and it protects them from getting RSV. You may remember a couple of years ago, before this was released, this treatment was released, the ICUs and hospital beds for pediatrics were just full of kids one season with RSV. It's really bad for little kids. So the infants can get that antibody, or you can vaccinate the mother in the third trimester, and she will produce antibody that she passes naturally to the infant and protects the infant. So there's two ways to protect that infant. The mother, she's going to get the antibody, it'll protect her, but otherwise healthy women, even pregnant women, don't have severe RSV. Okay. So anyhow, they looked at a whole combination of how you give these antibodies and how you give the vaccine, You give the vaccine only, you give the antibody only, you give them both, but you give the antibody later. I mean, it's a little bit confusing to describe it here, but let's just say it all works. Everything works. And so that's the good news. It's a study. It was also very well tolerated. Nobody had any big side effects or anything like that. This is a scientific study that looked at very closely, 181 um, pairs. So it's good. Any way you can deal with this, do it.
Mhm. And looking at the other end of the age scale, as you mentioned, elderly people tend to get very sick or can get very sick from RSV as well. We just got some new data about the efficacy of that vaccine. Can you share it?
Well, to put it into perspective, when you look at the big three or four, you've got flu, COVID, RSV, and you've got strep pneumonia, pneumococcal pneumonia, bacterial pneumonia, the big four. Those can cause a lot of problems, including hospitalization and death. So regarding RSV, like I said, it's recommended now for people 75 and older or down to 60 if you have some underlying disease. So this is the Kaiser Permanente of Southern California. They published this in Clinical Infectious Diseases, a highly respected infectious disease journal here in the United States, although it's published in England. And they looked at 8,200 individuals. And they found that the efficacy rate was 92%. Now, all the other vaccines that we give for respiratory infections, flu, COVID, pneumococcal pneumonia, the bacterial one, we're talking efficacy rates 30 to 50% or 60%, I mean, it's like you're lucky to get half. Now, half in a public health perspective is great. All right. If you can cut out half of the infections, there's 336 million people in this country. A lot of them get pneumonia. If you can help half of them, that's a good thing from a public health perspective. Imagine if they didn't get protected, how many more cases we would have. So 92%. This is incredible and safe. They're not reporting a whole lot of adverse events. This has been studied ad nauseum and so safe and super effective. I mean, if you're 75 or older, or you're 60 and you've got some underlying medical condition that puts you more at risk if you did get any kind of pneumonia, you're really crazy if you don't take this vaccine. This one works really well. And if you do get an RSV infection, it's a nasty one. So you really don't want to get it.
Mhm. Also of note, this is one shot for many years of protection.
Yeah, we don't. That's a good point, Katie. We don't know the antibody levels, the immunity that you have from one vaccine works for at least 2 seasons. There may have to be a booster every 3 to 5 years. Who knows? We don't know yet. I mean, because we're still following that first cohort that got vaccinated. So you'll have to probably have another one at some point. But so far, so good.
So far, so good. And a trend that is moving in the opposite direction are continued measles cases here in the United States. We touched on South Carolina last week. They've got some more, as well as other outbreaks across the US. Can you bring us up to speed?
Yeah, there's a big outbreak on the Utah-Arizona border with over 100 cases. Uh, and this is just the whole measles issue. This is not going away. And it is definitely not going away because they're looking at those cases very closely and they're looking at the school systems there. And remember, measles you can end up as kids in particular, but anybody can end up in the hospital or can die. It's like 1 to 3 per 1,000. So in this Arizona group, in the 2019 to 20 school year, 90% of the Arizona kindergartens were fully vaccinated against measles. Now, remember, you have to have 93 to 95% to really keep the infection down. Well, guess what? It has dropped to 78% fully vaccinated in the current school year. That means measles is not going away. It'll just stay at this lower level endemic number. There's just going to be measles all over the place forever if these numbers don't improve. When the entire United States had a vaccination rate close to 95% in the year 2000, we had 0 cases of measles. The only people that got measles had traveled abroad to countries that didn't have that high a rate. We thought measles was eradicated from the United States. It's not. It's here to stay forever.
Here to stay, and we will
It's
keep you
ranked very
updated.
low. Mhm.
Mhm. We will keep you updated as the US is now over 1,600 cases this year. Like Dr. Murphy mentioned, that is the highest number of cases since we eliminated measles back in 2000.
3 deaths out of the 1,600.
Mhm. Now, looking back at California, we talked about Mpox a lot, but all over the world. There are some concerning Mpox cases in California now. Can you tell us why we're so concerned?
Well, there's 2 clades or types of Mpox, number 1 and number 2. The number 1 is primarily in East Africa, and that's associated with a mortality rate of approximately 10%. It's more severe. 2 is the one that's mostly in Europe and North America, and that has a very low mortality rate, less than 1%. But I mean, you can end up in the hospital because of it. It's very painful, and there is a vaccine, um, and that's great. But what is new is that there's these 2 cases in Los Angeles and 1 in Long Beach, so 3 cases total that are Clade 1, the East African kind. And all 3 of those cases, the people ended up in the hospital. So more severe and potentially lethal. So, and these 3 people did not come in contact with each other. They're isolated. They've done the appropriate epidemiological surveys and tests to find out that these people had no interaction with each other. So it's out there, basically. So type 1 is here. So people at risk for Mpox, take the vaccine, please.
Mhm. 2 doses of that Jynneos vaccine are highly effective. Like the first round of COVID shots, it is recommended that you get 2 of those.
Yeah, no, 2 doses, right? Good point to bring it up, especially since we're talking about effectiveness of vaccines, 86 to 92% effective. So that's way up there for a vaccine.
Mhm. Speaking of things that are effective, over several decades, the United States and countries around the globe, excuse me, have put billions of dollars and millions of man hours into fighting tuberculosis globally. Unfortunately, with the cuts that the US has made to their funding, we will see major uptick in TB cases. Can you bring us the latest estimates?
Yeah, this is very unfortunate because the US was a very significant contributor to the big AIDS, TB, malaria program. And for TB, the TB program in particular, was very heavily subsidized by the United States. And that ended like instantly. So the predictions are that 9 million children in the next 10 years are expected to get TB, and kids are the most susceptible to it, under 5, and are the most likely to die from TB. So it's very important to focus on children and tuberculosis. So it's a kids thing. I mean, anybody can get TB, and anybody can die from it. But they predict 1.9 million deaths in children over the next 10 years or so. It's just very unfortunate. They're trying to fill the gaps. Of course, this is very difficult you just can't build this infrastructure overnight. Once you tear it, it's very easy to tear it down, very hard to build it back up. So we'll see what happens. This is an analysis done by Harvard and the Boston University Schools of Public Health. um, very nicely presented. And remember, TB is a disease that can be diagnosed, sometimes with difficulty, but diagnosed. It can be empirically or treated after a diagnosis is made. And you don't have to have you don't have to have like any deaths from tuberculosis if you have the systems in place to diagnose and treat. So the deaths are preventable.
Mhm.
Uh, Vaccines, have had just a very modest effect. They're working on new ones, but and they're working on new treatments. The treatment is long, months. It's not just like a 5 or 10 day course of antibiotics. So, all that goes into the equation in, how you deal with this problem globally.
Mhm.
It
And
happened in
speaking
the
of,
United States. We've had more cases this year as well. So it's not limited to outside the United States.
yes, disease knows no borders. It does not discriminate. But speaking of antibiotics, first a quick note, there was a massive conference, what is usually a massive conference here in North America called ID Week. Big attendance usually from Canada, from Mexico, from here in the US, and globally. A lot of the research came this week from that. Any notes on how that went this week?
Well, ID Week has become one of the world's biggest meetings to discuss all these infections, everything we've been talking about here. Um, I mean, it is the meeting to go to catch all the updates, what's going on, present your data if you have any, if you're doing research yourself. It's a great meeting. All our fellows go and all the trainees, most of the faculty, except for the ones still working. It ended yesterday, by the way, and it was in Atlanta, which is always it was planned like way ahead of time. Because there's the CDC is right there, so you have all the CDC people, and they're going to go to it anyway, usually. But of course, the government has basically shut down, and most of those CDC people that do this work have been fired. So there, so they weren't there, and the Canadians basically didn't come. They didn't want to come to the United States anymore. And the Mexicans they also didn't come. Mexico's 110 million people, I think. I mean, these are our neighbors. This is all these infections. The infection doesn't know any border. So the Mexican scientists did not come. And the Canadians didn't come. I mean, very few. And globally, people from Europe and stuff who do come, they have their own European meeting and Asian meetings, but a lot of them will come to this meeting because it's so important and whatever. Their attendance was way down as well. So in the whole scheme of things, there were 2,000 less people that came that were expected to come. So that was very disappointing. And I mean, I'm afraid we're going in this direction. This is not helping anything. You can see a lot of this stuff virtually. You can read the reports. All the data that we presented today was all from the written reports. But there's nothing, people. The reason why you have these meetings is for the personal interaction and to make all the connections with the people working in your field. I mean, this is just basic business, all right? And it's just unfortunate. Um, so that's the background. And then, but one of the good things, want to end up on a good note here, is Shinogi, which is a Japanese drug maker, has a drug out there called cefiderocol, if I'm pronouncing it right. It's used to treat the most serious hospitalized infections. And it is approved. And they just presented more data on it because they have these big longitudinal studies, 5 years studies looking at the effect of this thing. And they showed that in these very, very serious infections, that they using this drug resulted in more than half of the patients doing well in terms of being in the intensive care unit or other very serious report. And the overall clinical cure rate was 64%. And that's about as good as it gets with these super serious infections. And the reason this is important is that world globally, we talked about it in the last couple of weeks, the antibiotic resistant bacteria is growing. 1 in 6 infections now, the usual drugs are resistant. They don't work. And so this is this smoldering problem that's just percolating along here. And this is one of the drugs that works at least in 2/3 of the patients. But it's good that it works at least in that many. But the whole situation is not going to get any better. And that we need more of these drugs. We need even better drugs and to be able to treat people earlier or in a more effective manner to deal with this whole antimicrobial resistance issue. This is going to be the next sort of pandemic. It's going to be just these regular bacteria that are resistant to all the antibiotics. And the antibiotic, one way to develop resistance to the antibiotic is misusing the antibiotics, giving them when they're not needed, giving them for shorter periods or longer periods of time than are necessary. You have to do it the right way. It's very critical, and that's really the story. Oh, and then they also reported another one, a surveillance study called Sentry, and they showed that this drug was highly effective against a bacteria that is not effective against some of the other new drugs that have come out. It was one of the few agents that demonstrated activity against the super resistant bacteria that are floating around out there. So that's good news, but we need a lot more of it. But let's take the good news when we can get it.
Absolutely. And on that note, I'd like to thank you, Dr. Murphy, for your time and your expertise this week, breaking down all of the most important data and information for us. It's much appreciated.
Well, thank you, Katie, and have a great weekend.
Thank you. And thank you all for joining us this week for this week's episode of Ask Dr. Murphy. We hope to see you next week. And if you have any questions or comments, please leave them down below or at any of our social media linked in the description. Have a great weekend.